bit creative. Thank you.
Yesterday, Dr. Montoya noted that mast cell activation may play a role in this illness, and Dr. Susane Levine will be talking about that now.
Thank you, Tony. Hope my slides are going to come up. Okay. So mast cell disorder comprises a spectrum of diseases, most notably mastocytosis, systemic mastocytosis, which is a potentially serious neoplastic disease in which mast cells can be found in the skin and in other organs such as the bone marrow. Mastocytosis is relatively rare compared to what I'm going to mainly speak about, which is mast cell activation syndrome. So just briefly, however, mast cells are cells that are mostly located in the tissues. They're found in connective tissue and in mucosal organs such as the gastrointestinal tract and the bronchioles. Activated mast cells, as you can see from this not too well projected slide, produce many mediators. The ones that we hear about the most are histamine, but they also produce cytokines and leukotrienes. Eosinophils are also involved in producing cytokines or molecules that can contribute to mast cell activation disorder. Mastocytosis, once again, is a condition in which mast cells are always secreting histamine and tryptase. Mast cell activation disorders, however, are where mostly they're secreting these mediators when provoked. So that's probably the main distinction. So, like I say, I'm going to talk a little bit about mast cell activation syndrome and its potential role in connection with at least a subgroup of ME/CFS patients. And I've examined the literature on other disorders, which many of you are involved with: autism, Parkinson's disease, Alzheimer's, and some more common disorders like IBS, and even hypertension, in which mast cells may play a role and may shed some light on the pathophysiology in ME/CFS. I'm going to discuss some comorbidities and give a case presentation, provide some laboratory markers, treatment ideas, and just very briefly mention an article from Australia in which a unique mast cell phenotype has been found that expresses a toll-like receptor. Like I said before, mast cells are found mostly in tissues and not so much in the periphery. So it's a challenge to recognize these cells in the peripheral blood. So special techniques need to be developed in order to do this. So we're starting to do that. Like I said, systemic mastocytosis is mostly bone marrow or other organ involvement, and we're not going to focus so much on that here. The major criteria for mast cell activation syndrome involve you have a patient who, and oftentimes, like I said, with a lot of these things, you have to elicit these symptoms from the patient. Very often, they're not going to just tell you that because their main concern is PAM, post-exertional fatigue, the brain fog, sleep disturbances, etc. So you're going to have to ask specifically, do you get flushing? Do you experience hives or urticaria? Of course, you can ask about GI and neurocognitive complaints. And once again, there are IgE-dependent and independent triggers for release of mast cell mediators. IgE-dependent means your typical allergic triggers like certain foods, pollens, bee venom. IgE-independent triggers relates to things like mast cells, stress response, which involves potentially the HPA axis, and also viral or other types of infections can be independent or non-IgE dependent triggers. There is a validated mast cell questionnaire, which I think is quite helpful, and you can score that. Frequently, patients with some degree of mast cell disorder will have GI complaints such as nausea. Their symptoms oftentimes respond to H1 blockers. They will have chest pain, however, they will have a negative EKG. In some cases, they may have a positive EKG, however. I found something last night. There's a disorder called Curran syndrome, in which there are mast cells that are located around the coronary arteries and can mimic myocardial infarction. But in most cases, that's not the reason for the chest pain. Bladder pain, because mast cells are found in the bladders in some patients with interstitial cystitis, paresthesias, angioedema or swelling of the lips or tongue, telangiectasias or evidence of bruising in the skin, tinnitus, nasal congestion, and once again, these various cardiac manifestations, tachycardia, asthenia, fatigue, weight loss, memory loss, and I'll go on in a few minutes to outline why that might be. Some laboratory parameters are increased serum tryptase. Now, once again, in mastocytosis, systemic mastocytosis, the serum tryptase will be elevated most or all of the time. In people with mast cell activation disorder, you may need to elicit it with a challenge. So I would urge most practitioners to not dismiss this diagnosis in the face of a negative or low tryptase level. Elevated plasma histamine is obviously a good clue. However, patients should be on a low histamine diet and be off omeprazole, which can cause elevations in histamine. You really have to go after this diagnosis. So if the symptomatology is there, I urge people to continue to look for it in terms of laboratory markers. There's an elevated 24-hour urine methylhistamine. More esoteric and harder to get from your LabCorp Quest diagnostic lab is a 24-hour urine for prostaglandin D2. Elevated IL-6 is kind of an outlier, but response to therapy is a good way to gauge whether or not, at least one of the methods you can gauge whether or not this patient has some component of mast cell disorder. Now, gastroscopy will often show clusters of mast cells. Oftentimes, I've asked patients who've had a recent endoscopy, I've called their gastroenterologist, who's then gotten in touch with the pathologist, who's taken out the frozen section and then stained the gastric mucosa for CD5 positivity. And in a few cases, we've actually found it there. There are some mast cells present in normal gastric mucosa. However, the number of mast cells per high power field in the lamina propria is increased in mast cell involvement of the gut that's clinically significant. Colonoscopy may show similar findings. However, I haven't investigated the colon biopsies. In some cases, you may see splenomegaly, hepatomegaly, osteopenia, osteoporosis. Some other triggers that elicit mast cell activation are fasting, certain histamine-containing foods, sleep deprivation, and upright posture, which is likely linked to some degree, as Cindy talked about, of POTS or cardiac autonomic dysfunction. Now, some comorbidities, again, we're seeing this pattern of all these comorbidities that we see very clearly in our ME patients. The postural orthostatic tachycardia, most commonly the hyperadrenergic variety, which will be talked about in the case I'm going to present briefly. Fibromyalgia, autism, migraine headaches, Irritable bowel syndrome. Now, this is very interesting because in a cohort we examined at Columbia, we looked at ME/CFS in patients, the metabolome in those patients with and without IBS. Now, mast cells may be implicated as a causative factor in terms of the symptoms of IBS. And there are neurons in the gut that can interact with these mast cells. And when mast cell mediators are released, they can cause bloating and some of the other symptoms through the sympathetic nervous system of the gut. So there we have a mast cell neuro interaction, a gut neuro interaction. Okay, let me wrap it up quickly. Let me just run through this case presentation, which I think is quite illustrative. So we have a 43-year-old female who had MCAS since age 18. Foods triggered her flushing, rashes, dizziness. She had constipation, postprandial bloating, orthostasis, developed at age 23, hives, early satiety, dermatographism, vertigo, shortness of breath, insomnia, all are common complaints in ME patients. Her laboratory test showed a positive for hyperadrenergic POTS with an increase in heart rate of greater than 30 beats per minute and a rise in systolic blood pressure. Elevated serum norepinephrine, 24-hour urine, leukotriene, and 11 beta prostaglandins. And sorry, this is another case presentation. Okay, so the other thing that this patient had was EDS. And so she was treated with midodrine, and her POTS improved. She was also treated with H1 and H2 blockers, cromolyn sodium, which is a mast cell stabilizer, montelukast, and low-dose naltrexone, and her SIBO was treated as well. And many of her symptoms resolved. She also received IV gamma. Now, this is max treatment and probably not necessary in the usual patient, but I just thought it was illustrative of a lot of the different comorbidities and how they all occurred in this one patient. I guess I don't have time to explain all the rationales for why these different treatments might work, but improving the permeability of the gut allows reduction in mast cell recruitment, and that improves some of the IBS symptoms, and her GI symptoms improved by treating the SIBO. And the low-dose naltrexone regulated the T lymphocyte production, which also the T regulatory cells, which alter the cytokine, suppress cytokine release, which can also lead to mast cell activation, and block toll receptors, which stimulate mast cell activity. And the high-dose IVIG blocks the IgG receptors as well, which reduce mast cell release. So, okay, so let me wrap it up. Thank you for your attention.